Chapter 27, Medical Buildings for Participating Medical Practices. The author is Blair Kondorfer, architect. In 1977, the annual medical supplement to the Encyclopedia Britannica, there was an article about HMOs. It stated that HMOs were the future because they addressed the issues of cost and quality of care. It also stated that the public and the insurance companies would rail against them because of patient freedom to choose any physician or hospital. The article focused on group practice and staff model HMOs as the only ones that made practical sense in the achievement of the dual goals of lowering costs and increasing the quality of healthcare. Most of what was written in that article has come true, so that even the indemnity insurance plans have copied features of these HMO models in outward appearance. They have adopted managed care practices like pre-admission authorization, free approval for specialist referrals and diagnostic testing, and assignment of patients to primary care physicians for care coordination. Such adaptations are more economical than open systems like Medicare, but still far short of the outcomes that can be achieved in group and staff model HMOs. It takes no special wisdom to understand why. And of course, there are stories about HMO members not getting the care they needed because the HMO owners were greedy. Listen to Nixon's comment about Kaiser's profit motives from the Watergate tapes. An evolution of the IPA into a group practice model of care is coming. That could happen easily because the facilities being used by the primary care and specialist physicians change over short time frames as the owners are attracted to new medical office locations and buildings. If the IPA membership grows and the amount of money from that source of business becomes more important to the participating physicians than their other revenue, the IPA will construct facilities to exactly meet the needs of the practices within a group setting. This idea of group facilities for IPAs has been developed into a complete design of such facilities and the pricing of their manufacture and construction and equipping. There are three types of clinics in the designs: those that can be manufactured and put into site in about 60 days, and big box stores that can be converted into multi-specialty clinics, diagnostic centers, and surgery centers. The big box conversions are the most economical and will enhance the IPA's ability to keep most of the medical care in the local neighborhood where it can be delivered quickly and safely. And then specialty centers for new sites that are iconic in design, machine-like in function, and built with a high-quality material, safer for patient care, long-lasting, and economical. The new clinics are more attractive for the physicians to buy or lease than the usual medical office buildings. They are distinctive buildings that will be easily identified by patients as special places in which they can get quality health care. Descriptions of the medical service organizations and the facility projects. The patient population served by the primary care physicians of a local medical organization is about 30,000 lives. About 6,000 of these lives will have Medicare or Medicare Advantage health plans, and as many as 2,000 may be covered by Medicaid, and the remainder will be in private health plans. Providers are engaged in diagnosing, treating, and teaching patients medicine and health maintenance, and in providing care coordination. These services are currently provided based on fee-for-service agreements with as many as 60 to 70 insurers. However, since the passage of the Patient Protection and Accountable Care Act, there has been a shift by CMS and private insurers to risk contracts, as has been done in the past with HMOs. Health insurance has become a zero-sum game in which providers of care that make profits will do so from other providers in the game and not from increases in premium and taxes. The most likely targets for reduced income are hospitals, and the private insurer's administrative services. Specialists are the third target for reductions. The only way physicians can win at this game is by being in a medical service organization that can manage, coordinate, and facilitate the care that their patients need. The MSOs function best when they serve a defined population of at least 150,000 in a specific geographical area. The physicians must act as teams in the delivery of care. Since they are paid a capitation for their services, they will only be rewarded for performance by savings on facilities and insurer charges. The medical teams do this by reducing admissions to hospital and other high-cost facilities. Experience with HMOs has shown that medical teams can do that job well and cut costs by 15 to 20%. Average medical costs in the United States are twice as much as needed when compared with other industrialized countries. Therefore, savings of 15 to 20% are rather easy to reach. A team consists of 30 primary care physicians and 15 specialty groups for a total of 60 providers. It will require a medical director, chief operating officer, and chief financial officer, an accountant and IT specialist, 2 secretaries, and 10 patient physician advocates who work in the offices of the primary care physicians to help with training and care coordination. Fortunately, over the last 20 years, many of these teams have been organized and need only be joined into medical service organizations for contracting with insurers and CMS for the best capitation rates and the lowest risk exposure. The medical services organizations have been developed already, as well as a nonprofit physician association approved by the state medical board and empowered by the state to contract with CMS and insurers in risk agreements. Further, the managing partner of this association is a corporation that provides access to funding, general accounting, contracting, and legal services for all the local MSOs and for the association. The staff of this entity includes a medical director, a CEO, a CFO, 2 secretaries, 5 liaisons, 1 for each of the local MSOs. It also needs contractors for IT systems, data analysis, planning, marketing, design, and building of facilities, capital raises, and sales of health plans to members and their employee sponsors. The first step in the creation of the healthcare system is the capital raise. Given the feasibility of the project, the startup capital for 5 local MSOs in one region will be $30 million. Facilities which will be leased to these practices will cost $240 million. After the local MSOs are established, equipped, and trained, and the payer contracts obtained, and the patient populations are attributed, the next steps are improvements in communications and systems and population management. Specialty centers are a logical step toward making healthcare easier to access for the patient and their primary care physician. The medical organizations that are charged with budget responsibilities soon discover that staying within that budget without some local control over consults, final diagnosis, and prompt treatment is very difficult. Our company will build our specialty centers that serve defined patient populations located close to the patient's homes and the office locations of their primary care physicians. Finding a community hospital with a passing grade from Leapfrog organization is a daunting task. They count reported deaths and injuries first. Then they look at the experience of the staff in doing serious operations and procedures. There are 5 rating categories with grades of A through F, and nobody's gotten all A's. In fact, in Texas, the great medical centers, there was only 3 A's in one category, cardiovascular care, and it was not in the Texas Medical Center's famous hospitals, but in Scott and White Clinic, the big group practice HMO, West Houston Medical Center, and UTMB in Galveston. The other grades were C and below. Since this report from Leapfrog, several of the larger hospital systems in Houston have improved their grades. proving that people do want to avoid negative reporting. So physicians' ethics are to first do no harm, will try very hard not to use hospitals unless there's no other choice. The hospital problem can be solved, and there are two ways to approach it. Remember, the solutions are not for the whole community, but just for the patients enrolled with the IPA. Consequently, it does not take a very large hospital to handle almost all of the hospital care for a population of 150,000 patients. The admission rate for a senior population is between 250 and 275 per thousand per year, and for a under 65 population, it's 100 per thousand per year. The length of stay is 6 days for the seniors and 2 days for the under 65 group. Therefore, the number of beds needed is about 80. 10 of those beds will be level 3 hospitals. So so that your chosen community hospital will need only 70 beds to serve your patient's needs. The physicians could pick one hospital where they can influence the quality of care and drive away the natural desire of administrators and owners to perform only walletectomies. Or the physicians and patient community members could build a new hospital that fit their needs, was based on a better design, and had no entangling alliances that would put the administration into the wallet picking business rather than the patient caring business. A new hospital would address the issue of how the current facility designs contribute to the injuries and deaths of so many people. Most of the injuries and deaths come from bacterial diseases caught in the hospital, from medication mistakes, and from surgeries. When this problem was presented to our medical architects, they saw it as a traffic management problem, a communications problem, and a plug-and-play design issue. Observations of hospitals in which disease control problems are chronic showed that the buildings allowed for flow of patients, visitors, and supplies and medical staffs in all areas except the surgical suites. Just that flow meant it would be impossible to prevent bacterial diseases from spreading in the hospital and into the community as well. Blair designed a 2-corridor bed wing connected to core surgical and diagnostic suites with no public access to the suites. Visitors to the hospital were identified at the entrance and only allowed access to the patient's room that they had the right to see, and only through the public corridor. Walking past all the nurses, physicians, and other patients and visitors to see your relative or friend is not allowed. The communications would track medicines and patients directly from the pharmacy to the patient without mixing anyone or dispensing the wrong kinds or amounts of medications. Several of these systems are in use now in Texas hospitals, like the Harris system in Fort Worth. A hospital is not really a building. It's more like a big computerized machine. When it's thought of as a building, and when its property becomes a precious asset, it's no longer a hospital. It's an anchor that'll sink the medical care system. It's a museum in which the donors display their art and their golden nameplates. The public is sometimes impressed with this opulence, and some among them may be inspired to want a golden nameplate as well. When you see it as a machine, then you design it to use for its main purpose, the safe care of a patient. Let donors, visitors, physicians, staff, and suppliers socialize and conduct their businesses elsewhere. Don't put anyone in harm's way. The machine has a core with surgical and procedure suites. It then has plug-in diagnostic units, MRI, PT, CT, nuclear medicine, lab, and pharmacy. There will be upgrades and new kinds of plug-ins. You will not have to put the hospital into the deconstruction and reconstruction modes to make technical improvements. You will merely unplug the old unit and plug in the new one. The plug-and-plays are made in factories where the quality control can be better assured. Even the bed wings are plug and play and can be made elsewhere. Another aspect of this idea is that the hospital need not become larger on the site where it is located, but another core surgery, double cord, or bed wing plug and play hospital can be located near the population it serves. Even a town of 40,000 could support a facility like this with only 24 beds. Big facilities do not serve physicians or patients any better than small facilities, especially if small facilities are better machines. The hospital designs proposed by Blair are included in the supporting documents. Also, there is a summary presentation of his other major works, which show his talent, ability, and experience.